Please begin.
Good morning and welcome to the ISLAC webinar on multidisciplinary management of immune-mediated adverse events in lung cancer. This webinar is one in a series supported by ISLAC Education Committee and developed by the Nursing and Allied Health Committee. I'm Mary Ann Davies, an assistant professor at the Yale School of Nursing and oncology nurse practitioner at Yale Cancer Center. I am co-chair of the Nursing and Allied Health Committee for ISLAC and a member of the ISLAC Education Committee. I serve on the immunotherapy-related toxicity guideline panel for both the National Comprehensive Cancer Network as well as the Society for Immunotherapy and Cancer. I am joined by my colleagues, Kimberly Rowan, who is a nurse practitioner at the Edward Hematology Oncology Group in Naperville, Illinois. She's a member of the Nursing and Allied Health Committee of ISLAC and was the coordinator of the ISLAC Immune-Mediated Resource Guide. And also joined by Dr. Andres Charmalatis, Associate Professor at Cyprus University of Technology and the University of Turku. He is the President-elect of the European Oncology Nursing Society and Associate Editor of the European Journal of Oncology Nursing, who is also the recipient of the Nursing and Allied Health Travel Award for the World Conference on Lung Cancer. Our agenda today is that we are going to provide an overview of the landscape of immune-mediated adverse events, provide a presentation on a framework for the management of IMAEs. We'll then highlight in more depth two of the IMAEs seen in the lung cancer population, and this includes pneumonitis and dermatologic toxicities. We'll review a discussion of specific management strategies and principles of immunosuppression. We'll conclude our session with an opportunity for audience questions. These are my disclosures. Currently, immune checkpoint approvals are approved in multiple malignancies. In lung cancer, the approvals include 2 anti-PD-1 inhibitors as well as 2 anti-PD-L1. These indications include adjuvant, first-line, second-line, monotherapy, and combination therapies. The indications highlighted in the chart are those approved in the United States and not necessarily reflective of indications or approvals worldwide. In order to provide this overview, we're going to provide a framework to help guide us. Immune checkpoint inhibitors carry a specific toxicity profile that differs from standard cytotoxic or targeted therapies. Throughout this presentation, we will be applying the Champiet framework, which emphasizes the 5 pillars of managing immunotherapy toxicities. Specifically, we'll focus on pillar number 1, which is prevention and preparing for treatment. So for today's session, we'll be focusing on the preparation of professionals and their ability to understand and manage the immune toxicity spectrum. There are several possible mechanisms underlying immune-related adverse events. The mechanisms that result in immune-related adverse events are still being elucidated. Some potential mechanisms include increasing T-cell activity against antigens that are present in tumors and healthy tissues, increasing levels of pre-existing autoantibodies, an increase in the level of inflammatory cytokines, and enhanced complement-mediated inflammation due to direct binding of an antibody against cytotoxic T lymphocyte antigen 4, CTLA-4, with CTLA-4 expressed on normal tissues, such as the pituitary. In contrast to chemotherapy, immuno-oncology therapy has a different pattern and focus. The target is the immune system. It requires a functioning immune system. The evolution includes an introduction of new immunogenic targets via an antigen cascade. Pharmacodynamics are a delayed onset with memory conferred with this onset. Nishijima et al. Provided a systematic review and meta-analysis to compare the safety and tolerability between PD-1, PD-L1 inhibitors and chemotherapy. This included a look at over approximately 3,500 patients from 7 randomized clinical trials. Those toxicities with immune checkpoint inhibitor that were demonstrated across these studies demonstrate a risk ratio which favored PD-1, PD-L1 inhibitors. Overall, there was a lower total AEs with 67.6% with the IO therapy and 82.9% with chemotherapy. There were lower high-grade AEs, which is demonstrated in the plot above. There were also lower treatment discontinuation. These 3 were all statistically significant, favoring IO therapy. When we consider the possible patterns of immune-related adverse events, we understand that they can affect any organ system, some greater than others, depending on the T cells in the specific microenvironment. And we know that some systems may actually be immune sanctuaries. The patterns can differ dramatically. When we look at this retrospective review of clinical studies on reported immune-mediated adverse events, the graph demonstrates that several organ systems can be involved, and the pattern can vary with a median onset of 5 to 12 weeks after initiation. Yet we know that adverse events can occur within days of the first dose, after months of treatment, after discontinuation of therapy. There may be one organ affected or several. They may occur concurrently or sequentially. At this time, we do not have any biomarkers that provide us the opportunity to anticipate which ones will occur in which patient population. We do know that the severity and incidence is higher in anti-CTLA-4 agents. However, high-grade AE to one class does not preclude safe administration to another. There is a suggestion that there is a dose dependency, and we note that there's a cumulative effect with anti-CTLA-4 agents, which is not evident when we do an analysis of anti-PD-1 or PD-L1 agents. There is noted increased combination with other immune checkpoint inhibitors, as well as with combinations of targeted agents, chemotherapy, and radiation therapy. Most IRAEs are grade 1 and 2, as depicted in this graph, with the highest noted in the dark purple color, and that is with anti-CTLA-4 agents, and lower toxicity profile and the lowest with the anti-PD-L1, as depicted in this chart. You can see that to the right, the graph demonstrates that there is a significantly smaller percentage of patients that experience a grade 3 to 5 toxicity. When we look at all grade AEs, they do vary slightly by the class of drug as well. With the exception of fatigue, CTLA-4 incurs higher rates of toxicity. And when we take a look at infusion reactions, it's unclear, however, as to the etiology. However, PD-L1 agents are noted to have higher infusion-associated reactions. When we take a look at fatal IRAEs, chemotherapy fatalities average on 1.4%, and the fatalities are far less than that with IO therapy. Higher rates are noted with combination therapy, and earlier onset is noted with combination therapy, as noted in the upper graph. The lower graph demonstrates the leading causes of death, with colitis, pneumonitis, and hepatitis as the leading etiologies. However, you can see that there are other IRAEs fatalities that have been reported for all of the agents. The other important aspect of prevention is the consideration of patient assessment, and this includes evaluating patients for autoimmune risks, which may place them at higher risk for developing IRAEs. It's important to assess patients prior to therapy for prior organ transplantation or stem cell transplantation, as there is a risk for graft rejection. Medication reconciliation, including over-the-counter and herbal supplements, should be assessed, and this includes an assessment for immunosuppressant, immunostimulant, and immune modulating agents. The next pillar, pillar 2, in our management is to anticipate toxicities that may occur with our patient population. For the healthcare provider, it's important to do evaluations frequently, patient assessments, and that includes both pre, on treatment, and post-treatment, including full physical examination and laboratory evaluation. It's important that patients anticipate toxicities as well, and be sure to report the onset of any new symptoms that they have, and also any new medications or vaccinations, as there are specific guidelines that guide us in terms of administration for vaccinations, specifically that vaccinations that are inactivated or killed are permissible during the course of immunotherapy, and live vaccinations are currently not recommended. The next pillar in management is early detection, as we understand that patients that have toxicities identified earlier have a greater chance at being able to either restart, re-challenge, or continue safely on IO toxicity. Therapy with immune checkpoint inhibitors requires close monitoring and close communication with all healthcare providers. Symptoms that patients feel might be minor are often the first indication of IRAEs. Regular monitoring must be done to assess for early onset and also to assess for treatment responses. There are several available tools that can help guide the healthcare provider in monitoring, managing, and also the detection of IRAEs. These include standardized IRAE assessment tools, telephone triage guidelines, and the use of toxicity management guidelines. From a patient perspective, it's important that they closely have a mechanism to communicate with their provider, reporting any new signs and symptoms that may develop. Treatment is our next pillar for management. There are several clinical practice guidelines that have been developed over the course of the past few years that can help guide us in our management of IRAEs for patients. These include those that have been developed by the American Society of Clinical Oncology in conjunction with the NCCN, the Society for Immunotherapy of Cancer, the ESMO guidelines, and as well as AIM with immunotherapy. Many of these guidelines, most of them in fact, are consensus expert opinion statements. Some of them are available online and with downloadable apps or pocket guides that can be very helpful to the provider. In addition, there's a clinical practice guideline that was developed by the Nursing and Allied Health Committee of ISLAC, which uses a patient pocket guide to help guide the provider in looking at a systematic way of grading a toxicity, using green as the lower grade toxicity, yellow as a warning mid-grade toxicity, and red to highlight grade 3 through 5 toxicity. This particular guide is useful for providers as there are specific implications for lung cancer outlined throughout. In general, when we look at the management and treatment, pillar 4, of toxicities, grade 1 toxicities are typically asymptomatic diagnostic changes, and immune checkpoint therapy can continue with close monitoring. Grade 2 toxicity is mild to moderate, and there might be symptomatic or diagnostic changes. A provider should consider holding the immune checkpoint inhibitor and may consider restarting once it is improved to a grade 1 or less. If the in some cases, methylprednisolone or steroid might need to be initiated, and those are really specific by organ system. If the patient is improving on the dose of steroid as outlined here, there is a slow taper over 4 weeks. If, however, a patient does not respond within a few days, one should consider treating as a grade 3-4 toxicity. In grade 3 toxicity, the immune checkpoint inhibitor should be held, and there should be some consideration for whether or not it needs to be permanently discontinued, and one should cautiously consider whether one would like to restart or re-challenge the immune checkpoint inhibitor once it's improved to grade 1. In all cases of grade 4, patients should have the immune checkpoint inhibitor discontinued. The next and final pillar for managing patients on toxicity is monitoring. Once a patient is being treated for a toxicity, one needs to continue to monitor for resolution of the toxicity, monitor for complications of immune suppressant drugs, and monitor for treatment responses. We'll emphasize again that communication is the essential thread. We'll now specifically focus on 2 of the toxicities commonly seen in lung cancer, and I will pass the mic on to my colleague, Kimberly Rowan.
Kimberly, hi. We're having a little trouble hearing you. Are you speaking? Hello, Kimberly?
Can you hear me?
Yes, thank you.
Can you hear me?
Yes, can you
okay,
go ahead?
Okay, so we'll be talking about the respiratory immune-mediated adverse events, including pneumonitis, pleuritis, and granulomatous disease, as we go through talking about respiratory immune-mediated. We'll use the 5 pillars to discuss this, and as Marianne presented earlier, prevention is knowing what the spectrum is, anticipating what you can expect from patients, looking at how we detect it, how we're going to treat it, and how we're going to monitor it, and we'll use this as a focus for talking about pneumonitis. Pneumonitis is not common. It has been reported in up to 3% of patients of all grades, but only about 1% had grade 3 to 4. The duration of the treatment prior to the development of pneumonitis is variable, with a median of about 2.8 months, ranging from 9 days to 19 months. And was earlier for those treated with combination, either chemotherapy plus immunotherapy or radiation plus immunotherapy, rather than monotherapy, where in monotherapy it was 4.6 months versus 2.7 in combination therapy. When we talk about the principles of routine monitoring, at baseline, we want to do assessments on our patients. We want to measure their oxygen saturation at rest and with the ambulation. We've implemented within our center that any patient on immunotherapy does get routine O2 saturations when they arrive in the center, and then walking to the exam room for their assessment, so that we have those on a regular basis. We also look at pulmonary function tests for high-risk patients, which oftentimes are lung cancer patients are getting these PFTs through their pulmonologist on a fairly frequent basis. When we talk about monitoring frequency, you're going to repeat oxygen saturation test based on symptoms. So if a patient is complaining of more shortness of breath, more difficulty breathing, inability to do activities of daily living, we will repeat those saturations at rest and then again with activity. And then for evaluation of abnormal findings or symptoms, a consideration for a CT of the chest would be applicable. CT of chest would be also to make sure that we're not missing something like a pneumonia or pulmonary embolus or some other cause for their desaturation in monitoring. So we want to also make sure that we're not blaming immunotherapy when there could be another root cause for the patient's symptoms. So a pneumonitis presentation, oftentimes the signs and symptoms are a dry cough or a progressive shortness of breath with increased respiratory rate, chest pain, or dyspnea on exertion. Oftentimes those symptoms mimic other disease entities or other complications such as pneumonia or pulmonary embolus. So ensuring that you're teasing out with the patient, is this cough different than any previous cough that you had? Where is the chest pain? How short of breath or dyspneic are you able to walk 2 feet, 6 feet, 50 feet? So once again, that differential diagnosis, ensuring that we're making sure the patient does not have a pulmonary embolus or a pleural effusion or disease progression or infection as part of their presentation. When you look at the radiographic pattern of pneumonitis, you can see that it can vary based on patients. So they can have this fluffy appearance. They can actually have more of a rectangular kind of pneumonitis, and then they can also have almost kind of looks like snowballs thrown in their lungs, that they have various areas of increased inflammation. NCCN has come up with guidelines for the management of immunotherapy-related toxicities for pneumonitis. And when you look at the management for mild pneumonitis, you're going to consider holding the immunotherapy and reassessing in 1 to 2 weeks. Once again, you're going to make sure that you have that pulse oximetry at rest and with the ambulation to determine if the patient needs supplemental oxygen if they have not had it in the past. And consider a chest CT with contrast and consider repeating that in 4 weeks or as clinically indicated for worsening symptoms. For moderate pneumonitis, you're going to hold immunotherapy, consult pulmonologist, and do an infectious workup. Now, the infectious workup is going to be different based on if this is single agent or if they're in combination with chemotherapy and they're neutropenic. So you want to ensure that you're checking their CBC to see if they're neutropenic. If they're neutropenic, then you're going to be a little more aggressive in getting cultures, blood cultures, urine cultures. And then you would consider doing a bronchoscopy if patient is not improving on treatment. Consider CT of the chest with contrast, and once again, CT repeat in 3 to 4 weeks for resolution. Consider antibiotics for somebody who's you suspect infection and or is also on combination therapy. And the treatment is prednisone or its equivalent at 1 to 2 milligrams per kilogram per day. Monitor every 3 to 7 days with H&P and pulse oximetry. And if no improvement, and then you're going to slowly taper those steroids over at least a 4 to 6 week period. If there's no improvement after 48 to 72 hours in patients you didn't initially start steroids, you will start steroids at that time. When we look at severe pneumonitis, you're going to permanently discontinue immunotherapy, and most of the time those patients need to be admitted into an inpatient setting where they can be closely monitored. You will continue to do the infectious workup with patients looking for viral etiologies as well as bacterial etiologies. And consulting pulmonary and infectious disease consultation and considering PFTs at the bedside. Bronchoscopy would be something that we would consider if a patient does not improve within 48 hours to 72 hours. Antibiotic therapy, if one is suspicious that an infection is the root cause of the symptoms. And once again, the prednisone at 1 to 2 milligrams per kilogram per day and tapering over at least a 6-week period. Consider adding one of the following after 48 hours. There's infliximab and mycophenolate. The studies in considering IVIG, the studies with infliximab were mostly done in colitis, less in the pulmonary toxicities. For the most part, the additional medications were shown to not be that the steroids were still the most effective way of managing pneumonitis in this patient population. This is the grading system that Marianne alluded to previously that was developed through ISLAC, which talks about the grade 1, 2, 3, 4. Once again, pulse oximetry is so important, and I think oftentimes you can see trends in pulse oximetries from visit to visit. And as I like to teach our medical assistants, you can kind of see the train coming down the track where the pulse oximetry may be 96 and then the next time it's 94 and the next time is 92. You can kind of predict that something's starting to occur in most of these patients. If it's a grade 1, you are going to continue therapy. Grade 2, oftentimes in grade 2, it's limiting their ability to care for themselves. You may consider an X-ray to make sure that it is not a pneumonia or pleural effusion. You will withhold therapy and initiate steroids with a slow taper and resume therapy once again when the patient's grade 0 to 1 or when the prednisone dose is 20 milligrams per day or less. Grade 3 and 4 and 5, obviously you're going to you are going to permanently discontinue therapy, administer steroids, and that's when the workup becomes more aggressive with CTs of chest and potentially looking at bronchoscopy if patients are really compromised and not improving on the steroids with a slow taper. Oftentimes, patients with grade 3, 4 with lung cancer have underlying emphysema or COPD. So oftentimes those patients, the it's very quick for them to go from grade 2 to 3, and oftentimes grade 3, 4 patients are admitted to the hospital for close monitoring with pulmonary and infectious disease as required. When you talk about cough, cough is also one, and hypoxia is another adverse event that can happen. With the cough, most oftentimes it's mild. Checking for infection. Grade 2 is very similar to what you would do for pneumonitis, and grade 3 is also very much what you would consider doing for pneumonitis in checking CT scans and initiating steroids. And if the cough is a grade 3, you will permanently discontinue therapy. Hypoxia, once again, is very much the same as cough, and you will continue, I think, once again, reiterating that pulse oximetry is the cornerstone to really monitoring how these patients are doing and determining when to continue therapy, when to hold therapy, when to discontinue therapy, and when steroids should be initiated, and at what dose with a taper of at least 6 weeks. So when we go to treatment, the guidelines for steroid treatment is rapid taper will most often result in recurrence of the toxicity, so you will taper over at least 30 days, most of the time 30 to 45 days. Consider gastritis prophylaxis with a PPI, especially if patients are on high doses for a period of time. Gastritis can become a problem. In diabetics, you're really going to want to monitor their glucose and include their endocrinologist or their primary care who's managing their glucoses to ensure that we're keeping those glucoses and not having patients go into DKA. Infection risk, one could consider doing Bactrim and antifungal prophylaxis, especially on patients that are going to be on steroids for a long period of time. And then osteoporosis risk, vitamin D and calcium or calcium carbonate with vitamin D is recommended, especially for patients who already have osteopenia or have osteoporosis. So once again, the pulmonary toxicities we're going to anticipate and prevent. So anticipate pneumonitis on single versus combination immunotherapy. For prevention, you're going to especially watch those patients who have exposure to heavy smoke areas, encourage smoking cessation, and make sure our patients have their vaccinations are up to date. When you anticipate, you also want to make sure that there's pneumonia versus PE versus congestive heart failure. Oftentimes heavy smokers and our lung cancer patients also have underlying cardiac disease. When we talk about monitoring, you're going to monitor for shortness of breath, dyspnea, chest pain, persistent cough, fevers, or worsening fatigue, and once again, that pulse ox at rest and ambulation. For management, we want to educate patients about these side effects and the importance of letting us know so that we can catch these immune-mediated adverse events at grade 1 and 2 where we can still potentially continue therapy and patients do not have to be permanently discontinued. We'll end this part with a case study. BC is a 76-year-old male with a diagnosis of stage 4 non-small cell lung cancer. He is now on nivolumab, 240 milligrams every 2 weeks, infused over 60 minutes. Today he reports that for the past 5 days he's had shortness of breath, cough, and dyspnea on exertion. His O2 sats at room air were 95% and 89% during ambulation. What would be the best course of action? This patient, once again, you're going to anticipate. So he's grade 2, so a chest X-ray or CT and anticipate a steroid taper. We start off with a chest X-ray. We start off as a chest X-ray in this patient who had a history of pleural effusion to ensure that that wasn't recurrent or an infection. If the chest X-ray is unremarkable, then it's strongly encouraged to move on to a CT scan and once again starting steroids. This was the imaging, the chest X-ray, and you can see in this screen here that he has diffuse pneumonitis throughout both lungs. He was treated or was started on prednisone at 1 milligram per kilogram, 60 milligrams daily, and treatment was held. What other medications would you consider? Once again, slow taper over 4 to 6 weeks. You can try to decrease by 5 milligrams every 3 days. In my experience, sometimes it may be longer, more in the range of 4 to 5 days. Because it's a high dose of steroid, Protonix 40 milligrams daily, monitoring the glucose. He was not diabetic, and started the patient on Bactrim and voriconazole for prophylaxis for infection risk. Patient also had some osteopenia, so was started on a vitamin D and calcium supplement. So he was once again started. He's been weaned down to 10 milligrams daily after 4 weeks. Can you restart therapy? Yes, it's okay to reinitiate therapy once patient is off steroids, or down to 10 milligrams or equivalent per day, and their symptoms, there's grade 0 or 1 with their symptoms. So monitoring, it's really, as Marianne alluded to earlier, it's very, very important that we continue to monitor patients very closely for resolution of their symptoms and to ensure that there's not recurrence. So it's very important that we continue to establish a close relationship with patients to ensure that their symptoms do not get worse and that they do not recur, or that we need to, sometimes as we're tapering, do we need to go back up 1 dose for a few more days and slow the taper down? So it's very, very important that we're keeping close contact with these patients. So now I'm going to turn the presentation over to Andreas, who will be presenting on dermatologic immune-mediated adverse events. Thank you.
Thank you, Kim, and good evening, everyone. Following the presentations by Marianne and Kim, this presentation will provide an overview in terms of the management of immune-related mucocutaneous toxicities. But firstly, these are my disclosures. Immunotherapy-induced toxicities can include many different types of toxicities, included but not limited to maculopapular rash, pruritus, for example, toxic epidermal necrolysis, Stevens-Johnson's syndrome, just to name a few. The incidence of skin toxicities in immunotherapy is quite high, and it is reported in the range of 30 to 40%. It is actually rated amongst the highest toxicities reported. However, the incidence is also dependent on the type of the immunotherapy checkpoint inhibitor. So, for example, rash and pruritus are reported in 24% and 25 to 35%, respectively, of patients treated with ipilimumab, in 9 to 10% of patients treated with anti-PD-1 inhibitors, increasing to 15% and 25% with the anti-PD-1 and anti-CTLA-4 or chemotherapy combination. Now, in terms of the kinetics of onset, specific patterns have been recorded in the literature. So according to this pattern, we can see that skin-related toxicities tend to occur first. Colitis appears next after 1 to 3 doses, and hepatitis and endocrinopathies tend to occur last, often after the 3rd or 4th dose of ipilimumab. Similar pattern occurs in nivolumab and pembrolizumab. And here we can see the patterns that I have just reported. Now, in terms of the dose relevance to toxicities, whilst a dependency was observed with ipilimumab, showing that toxicities are dose-related, because the rate of grade 3 to 4 drug-related serious toxicities increased from 5 to 18%, when the dose was increased from 3 to 10 milligrams per kilogram and was 0 at dose of 0.3 milligram per kilogram. Such dose dependency, however, was not observed with nivolumab. In terms of assessment, according to the common terminology criteria for adverse events, there are 4 grades, and grade 1 includes macules and papules covering less than 10% of the body surface area with or without symptoms. Grade 2 includes macules and papules covering 10 to 30% of BSA with or without symptoms, however, limiting instrumental activities of daily living. Grade 3 includes covering over 30% of BSA with moderate or severe symptoms, limiting mainly self-care activities of daily living. And grade 4 is papulopustular rash associated with life-threatening superinfection, Stevens-Johnson syndrome, tan and bullous dermatitis covering over 30% of BSA, and mainly, most importantly, requiring intensive care unit admission. However, these severe grades of toxicities only occur in a very small percentage, usually less than 2%. In terms of management guidelines, as reported earlier both by Kim and Marianne, a good strategy to deal with the management of also mucocutaneous toxicities includes the 5 pillars of proposed by Champion, that includes prevention, anticipation, detection, treatment, and monitoring. Classically, prevention includes knowing the immune toxicity spectrum and identify any disimmunity risk factors. Anticipation includes baseline checkup, on-treatment follow-up, and off-treatment follow-up. Detection includes baseline values, which are equal to reference values, eliminated progression. Treatment includes symptomatic treatment and providing patient information, discussing issues such as immunotherapy suppression, refer to organ specialists, corticosteroids, other immunosuppressive drugs, and finally monitoring resolution of kinetics, relapse, recurrence, and immunosuppression complications. As time is relatively limited, I will be presenting an overview in terms of maculopapular rash and pruritus. In terms of the rash, this typically implies an acute and generalized eruption. From a morphologic point of view, it is characterized by the presence of macules, which are flat-skin lesions less or equal of 1 centimeter in greatest diameter, and papules, which are raised bumps less or equal of 1 centimeter in diameter. The NCCN has provided management guidelines, and this is the most recent update, the most recent version, following the assessment and grading of the maculopapular rash, which includes total body skin exam, including the mucosa areas, assessment for history of prior inflammatory dermatologic diseases, and also consideration of biopsy if unusual features are present. Generally, we have 3 categories in terms of grading. We have mild cases, moderate, and severe, which include grades 3 and 4. And in terms of management, for grade 1 categories, mild categories, we continue immunotherapy. We should apply topical emollients, oral antihistamines, treatment with moderate potency topical steroids to affected areas. Moderate cases are treated again with topical emollients, oral antihistamines, treatment with high-potency topical steroids to affected areas, and or prednisone in the range of 0.5 to 1 milligram per kilogram per day. Moderate cases of maculopapular rash, we should consider halting immunotherapy in specific cases. Severe cases, which includes grade 3 and 4, we halt immunotherapy, treatment with high-potency topical steroids to the affected areas, again prednisone on the same doses as moderate cases, and consider increase of dosage up to 2 milligrams per kilogram per day if there is no improvement with less dose. These severe cases should be considered as urgent dermatological conditions, consideration of inpatient care, and as I emphasized in the beginning, these are cases that should be considered for halting immunotherapy. As Marianne presented in the beginning of this webinar, there are also other management guidelines that are freely available in the literature. For example, the ones provided by the European Society of Medical Oncology, published guidelines by NIDU and corporates, and of course the research guide provided by the International Association for the Study of Lung Cancer. There are very, very slight variations between these management guidelines, and this should be considered in any cases for the management of maculopapular rash. Now, in terms of pruritus, as stated earlier, this is a toxicity that approximately affects 30% of the patients. It is associated with rash and cirrhosis, and it is believed that the underlying mechanism is enhanced immune system activation in the skin. Overall, pruritus minimizes patients' perceived quality of life, as this was indicated in recent studies. Again, I will be lay down the guidelines provided by the National Comprehensive Cancer Network. Following the assessment and grading, which should include total body skin examination, including mucosal areas, and the assessment of history of prior inflammatory dermatologic diseases, as in the case of maculopapular rash, but there is no reason for skin biopsy in this case. Again, there are three different categories, including mild, moderate, and severe cases of pruritus. In the mild cases, we tend to continue immunotherapy as planned. We consider oral antihistamines, treatment with moderate potency topical steroids to the affected areas. Moderate cases, we continue immunotherapy with intensified antipruritic therapy, continuation of oral antihistamines, treatment with high-potency topical steroids to the affected areas, and the patient is sent for dermatology consultation. Severe pruritus should be, we should consider halting immunotherapy, continue oral antihistamines, prednisolone in the range of 0.5 to 1 milligram per kilogram per day. Consider GABA agonists, consider aprepitant for refractory cases, and they should also be treated as an urgent dermatological for dermatological consultation. Following, there is an interesting case published in the Lung Cancer Journal. This is a case study of advanced non-small cell lung cancer treated with nivolumab. It is a 76-year-old Japanese woman with advanced non-small cell lung cancer. After the second dose, she experienced severe maculopapular rash with mucus involvement. she was diagnosed with Stevens-Johnson syndrome, and she started 50 milligrams of oral prednisone. The rash completely resolved. However, pruritus was unremitting with emollients, antihistamines, and steroids. She was put in epidurals in 80 milligrams QD for 5 days, and then pruritus improved within this 5-day duration. Just to recap, things to remember: first requirement, rule out any other skin toxicity etiology, such as an infection, drug interaction, or another systemic disease. Proceed with complete physical examination, including mucosal areas, for defining the exact BSA affected by the toxicity, plus blood tests with liver and kidney function. Other things to remember: the grade 4 skin rash associated with life-threatening infection, Stevens-Johnson syndrome, toxic epidermal necrolysis, and bullous dermatitis covering over or equal 30% of BSA require intensive care unit and systemic steroids plus biopsy. And finally, management of immune toxicity. We should not forget reminding our patient that it is not chemo, and therefore the side effects profile and management is not like chemotherapy. Early notification is key. Early recognition of these side effects and initiation of treatment are critical to reduce the risk of sequelae. Providing handouts and emergency cards for the patients to carry with them should be something to consider, and refer patients to appropriate specialty for further follow-up and management of toxicity. Thank you very much.
So thank you. We'll now take some other considerations. We've had an opportunity to hear from Andres and Kim on 2 of the most common toxicities, but it's important to keep in mind that there are several other organ systems that may be affected by IRAEs. The first rule of thumb when one is trying to assess or detect is to rule out other causes, because the diagnosis of IRAEs is often a diagnosis of exclusion. So a few examples: for a patient who develops diarrhea or colitis, it's important to rule out infection, and so obtaining stool cultures will be important. For patients with hepatic toxicity, it's important to consider whether or not they are on other hepatic toxic drugs, and to hopefully minimize those or remove those from the treatment to see if that helps to resolve the issue. In the case of renal toxicity, it's important to assess for nephrotoxic drugs and dehydration. So some nephrotoxic drugs such as other chemotherapeutic agents, antibiotics, NSAIDs, and contrast dye will place a patient at higher risk for developing the toxicities. And in the interest of time, we do not have time to go over every single toxicity, but again, important to do a thorough assessment of every organ system, and be sure to work with your multidisciplinary team, as often the management of these toxicities is going to require the consult of subspecialists to keep patients safely on treatment and to manage the toxicities. In terms of the guidelines for steroid use, Kim did go over the taper of 4 to 6 weeks, and we do know in certain cases that there is a need perhaps for longer tapers, such as in the case of pneumonitis and hepatitis, in which case sometimes 4 to 6 weeks of taper is required. Kim has already gone over the monitoring. In terms of prevention and anticipation for gastritis, the patients at highest risk are going to be those on NSAIDs and on anticoagulation, so they should promptly be started on proton pump inhibitors or H2 blockers. For patients at risk for opportunistic infections, those are patients that are receiving at least greater than 20 milligrams of prednisone or equivalent for more than 4 weeks. And if that's going to be anticipated, they should be started on prophylactic antibiotics and fungal agents. And those patients that are at risk for osteoporosis are those that are on steroids for a protracted period of time. So steroid use in itself is also presents potential complications for patients. While the glucocorticoids are beneficial in managing inflammatory conditions, there is a concern that some of the side effects may limit the dosing or adherence and also the duration of steroids. Most of our patients, when they are started on steroid, are going to be started at what we consider a higher dose. So if it's 1 milligram per kilogram per day, it will fall in the high dose range. And what we know from other studies is that patients with long-term use, which is more than 60 days, even at low doses of less than 7.5 milligrams per day, do exhibit some potential AEs associated with the steroids. 90% of patients in this study actually reported at least one steroid-related or associated AE, while 55% report that at least one of those side effects might be bothersome. So, of course, there is some concern that healthcare providers have, as well as patients. What is the risk and what is the impact of using steroids in our patients, and what is the impact on outcomes? So some studies have actually shown that there's a higher response rates in patients that exhibit IRAEs, but it doesn't seem to be that IRAEs are required for a response. And we've certainly seen this has actually been demonstrated in several other malignancies. In terms of steroid use and immune checkpoint blockade efficacy, there is some preclinical data and anecdotal that suggested that the steroids might reduce efficacy of the immunotherapy. However, recent clinical studies have not found that to be true, and that has to do with steroids. The steroid impact reduces naive T cells, but they have little impact on the effector or memory T cells, which is what we are elucidating when we are using checkpoint therapy. In terms of the management of steroid refractory AEs, there are some cases when the toxicity is not responsive to the initial dosing or after several days. There are additional immunosuppressant agents that have been used in clinical practice. Most of these do not have IRAEs as a clinical indication in their package insert, and the data for use of these has really been extrapolated from other autoimmune diseases. So in the case of diarrhea or colitis, we've used infliximab, and if patients are unresponsive to that, there are vedolizumab has been used for grade 2 to 4 infliximab-resistant IRAEs. For hepatitis, infliximab should not be used due to the risk of activating hepatic injury. In this case, mycophenolate can be used in grade 3-4 toxicity. Pneumonitis, one can use a variety of different secondary immunosuppressant agents. And then additionally, you can see on this chart that other agents have been used. In the case of neurologic toxicity, this will be dependent on the exact type and the degree of the toxicity, but IVIG has been used. And other disease-modifying agents have been used in rheumatologic toxicities. The other question is, when can one or could one consider the reinitiation or rechallenge of immune checkpoint inhibition? And this chart outlines those considerations based on the NCCN guideline. In general, if a patient has a low-grade toxicity and they are responsive to the immune suppressant agent and get down to a grade 1 or less than a dosing of prednisone equivalent of 10 milligrams per day, one can consider rechallenge. However, if one looks to the right-hand side of the chart, there are certainly cases of grade 3-4 toxicities in which one should not consider rechallenging the patient with the immune checkpoint therapy. So there are some additional strategies one can incorporate into their practice to help enhance patients' tolerance and also manage toxicities. This was a report by Hanley who suggested that there are certain actual best practices that can be incorporated into practice, and that includes enhancing access and care coordination through monitoring systems, through appropriate care transitions, automated hovering, which really just refers to the ability to use automation as reminders and a form of communication with patients. Standardized clinical pathways for symptom management are supportive, and we need to consider that these need to also be shared with other departments, such as emergency departments, in which a patient might present themselves. And we've shared several of those pathways with you. It's also important to develop urgent care tactics, as oftentimes patients might be presenting to emergency rooms, and so having those providers prepared is critically important. In terms of telephone triage, as I said, the onset of IRAEs can vary widely, and patients are likely to be outside of the clinic upon the onset. In fact, a look at the emergency department use by patients treated with an immune checkpoint inhibitor, 25% of those visits were due to an IRAE. So what's important in terms of our patient communication and education is that we need to do an assessment as to how reliable a patient is and how accurate a historian they are. How reliable is the patient to follow telephone instructions? Are there language barriers, cognitive deficits, or other comorbidities or other influence that might impair our ability to safely have adequate communication with our patients? And these important considerations should take place even at the start of therapy and throughout. So in conclusion, immune checkpoint therapy offers great therapy options for patients with lung cancer. However, there are some associated and potential immune-related toxicities. We have presented several comprehensive guidelines that are available in a variety of different sources to support clinicians' management of the toxicities. But it's imperative that a multidisciplinary coordinated team is engaged and required to safely support patients on therapy. So I'd like to just acknowledge my team as well as my fellow speakers, Kim and Andres, for joining us, and as well as the Education Committee of ISLAC and the Nursing and Allied Health Committee for supporting this effort. And we will now take questions from the audience if anybody has any. And I'm not sure if Julie is on. I've got one that I have. Should corticosteroids be discontinued when an alternative immunosuppressant is started? That is a really good question and one that has been discussed in the literature. Most providers will continue on corticosteroids when an alternative, an additional immunosuppressant is started until the patient is stabilized and then begin tapering off the steroid. Part of it is going to be dependent on the exact toxicity and also the immunosuppressant that is used. Are there any other questions? I'm going to try and scroll through here.
If I may say so here something, I see a question about what activities of daily living are. Just to give the definition or what it relates to, this is a series of basic activities performed by an individual on a daily basis, which are necessary for an independent living at home or in the community. Basically, these activities are categorized in 5 different levels. There are personal hygiene, dressing, eating, maintaining continence, and transferring and mobility. Thank you.
Andre, there's another question here that is, have you ever heard of the use of sun tanning beds for pruritus?
What was the question? I couldn't hear you, Julie.
This is Marianne. Have you read of any use or anecdotal experience with the use of sun tanning beds for dermatologic toxicities?
Well, I haven't came across any studies or anecdotal, but looking back at the mechanisms behind pruritus, I would say that a sun tanning bed will exacerbate the cirrhosis of the skin, and I would say this will make things more serious for the patient and not less. But I haven't seen any study on this, to be honest.
Great. So another question is, do you use voriconazole prophylaxis on every patient treated with the immunosuppressant? In general, the guidelines suggest that if patients are going to be on protracted courses, so more than 4 to 6 weeks, and if they are a patient that is at higher risk for developing fungal infections, then that prophylaxis should be initiated, and viral prophylaxis should be initiated as well. So those patients might be somebody that's received maybe had another hematologic malignancy or undergone stem cell transplant. Those would be patients at higher risk for developing kind of reactivation of those type of ailments. But typically, if a patient's going to be expected to be on for just 4 weeks, then that is not in the recommendations. Let's see if there's any. The other question is, when do you vaccinate your patients? So typically, patients should be having their routine inactivated vaccinations prior to the start of therapy and as regularly scheduled. So if, they should have their yearly flu vaccination, influenza vaccinations, and the pneumonia every 5 years or by national, whatever your national recommendations are. And so at the regularly scheduled time is when patients should have those done. It is not recommended to administer any live vaccines, however. So I've got, so another question came in is, does one done TB testing prior to treating high-risk populations? So one of I'm assuming that one of the reasons for that question is that infliximab carries with it a warning that it may lead to reactivation of TB in certain populations, and so or the development of that. And so in the package insert, it does recommend testing. However, in most of our cases, when a patient develops something like a colitis, it's usually more acute, and we don't have the luxury of waiting for that test to declare itself. In a patient who perhaps might be at higher risk, and this is something that we are seeing more clinically now, is that, for instance, a patient who has a long-standing history, let's say, of ulcerative colitis or colitis in general, they may be refractory anyway to corticosteroid use. And so if one would anticipate the potential need for using infliximab, you might proactively assess that patient. Great questions. Let's see if I see. So another question, which is one that we often get, is, should one change the dose of the immune checkpoint inhibitor when it's restarted? And over how long a period should one restart at full dose? Kim, do you want to grab that question?
Sure. So typically you do not do dose adjustments. Patients are either you get treated or you don't get treated. So there's usually no dose modifications. Most oftentimes we'll restart the patient once their symptoms are controlled and their steroid dose is less than 20 milligrams per day. And you'll, once again, remember one of the pillars was monitoring. So you'll monitor those patients very, very closely for reactivation of the immune-mediated adverse event, no matter what it is. But so there's never dose reductions. It's either the patient gets the dose or does not get the dose.
Fabulous. Well, it looks like that was the last question. I thank you all for joining us today and this evening for this session, and hope this was beneficial, and you'll be able to have access to these slides online in the near future for your reference. Thank you all. And Kim and Andre, I think we're going to stay on the line if we can for a moment.
Do you need to go behind the curtain to speak?
Sure.
Okay, hold on.